This is Jennifer, the SDC for Life Care Villa Center for our December 2024 in-service meeting. We covered 3 topics: risk management, person-centered care, and change in condition. So some housekeeping items first. Number 1 is do not use the tap water for drinking. This water is not filtered, and so if you get any water for drinking for yourself or for the residents, you want to be getting it from the coolers, especially with the pitchers that we keep on the medication carts. And then if you are filling up their individual cups, you want to make sure that you're using that water from the cooler. Just as a reminder, be using the residents' names and not their nicknames like Sugar, Honey, Darling, anything like that, unless it's listed on the plan of care. When it comes to central supply, if Derek is not in there, then you want to make sure when you leave that door is locked. For transfers, whenever you open the residence chart, their recommendations, they are going to put that under their plan of care, but it's also listed, not lister, but listed under special instructions for how you are supposed to transfer them. So if it's a 2-person assist, if it's a sit-to-stand lift, that should be under special instructions. Also, I just learned that this week, but you're not supposed to lift a resident under their arms. So if you've got a gait belt on them, you're not supposed to grab them under the arm, but you actually want to hold your hand out and have them grab onto your hand, and then the other hand should be under the gait belt. When it comes to CPR, if you are doing any of the online trainings, just remember you have to do a hands-on portion where you actually demonstrate your CPR skills on a mannequin. If not, then it is just considered first aid training. Now, I schedule a CPR class pretty much every single month, and it is free for it to be taken here. Lastly, when it comes to the heat and air conditioning, just be aware that federal and state law, they mandate that we have to keep our facility, all the thermostats, between 71 and 81 degrees. And I know at times that can definitely suck, but that is law. And so we need to make sure that we are not changing those thermostats to read below 71 or above 81 degrees. All right, so when it comes to the oxygen tanks, I actually went into the closet the other day and it was kind of a hot mess. So just want to point out, we've got these signs says empty, so we should be finding the empty oxygen tanks over here and the full ones here. And then when it is first, they fill them all up, then he's going to start here, and that is focusing on my finger instead of on the diagram. But we are going to start over here, and then we're supposed to work our way over to the corner. So when you walk in from the door, the empty oxygen cylinders should be against that back wall and the full ones to the right. Now, when you're grabbing a full oxygen cylinder, you shouldn't be grabbing from over here. You should be grabbing from up here and working your way over and then down. If you're confused, then, ask myself, ask Derek, one of us, ask Glenn. Any of us will be happy to help you. But we're just trying to make it so that when somebody walks in, they can easily identify where the empty and the full oxygen cylinders are. So our first topic is on risk management. And then the thing about risk management is we want to prevent accidents from occurring in the first place. We don't want to wait and then react when actually something does happen. Though that's often one of the best ways to identify risk is by near misses and good catches. Of course, the challenge of risk management is worsened by staffing shortages. And we all know that when we're short-staffed, then we have higher workloads. And a lot of times that leads to us cutting corners, which can cause some accidents. So some of the common risks for the nursing facility are falls, medication errors, pressure ulcers, and infections. And falls is actually the most prevalent risk. And causes of that can be, of course, mobility issues, sometimes side effects from medications and environmental hazards. And so these are the ways that we can prevent those risks from happening. So basically, if you see something, say something, whether that's an environmental hazard, like something is in a pathway, like a cord or a rug, or there's moisture that's on the floor. Definitely want to make sure that our residents are wearing that non-skid footwear and keeping that call light near and answered timely. We have had residents that, man, they probably haven't walked in weeks, but they've decided today's the day, and they're not waiting for you to answer that call light, and they're going to try to make it to the bathroom on their own, and then we have a fall. So we try to get those call lights answered timely, or if that's not your hall, or if you're housekeeping or administrative staff, if you see a call light on, just stick your head in there and let them know that their aide is busy down the hall, but that they will be with them just as soon as they can. Because from the resident's point of view, all they know is they're laying in that bed, and they might have had 5 or 10 people walk by, and they don't know if you're a nurse, a CNA, Jim Bob from down the road. So, if you got just a minute, just stick your head in, because sometimes it may be something as simple as, can you turn the light off for them? All right, another risk that we have is medication errors. And you can see the examples of that on the screen. Ways to prevent that, make sure you're looking at those allergies, checking contraindications. So like for my dad, they had given him some oxycodone about a month ago. Well, they didn't tell him not to take his tramadol as well, and we almost had an overdose because of it. He actually had a lot of problems, was having to use his inhaler every couple of minutes, and really worried my mom, but they didn't call me until the next day, and I literally lived 2 streets over. And I told her, what had happened, and that they really should have used the Narcan for him. Also make sure, if you're giving medications, that you are checking those medications 3 times, and that you're remembering those 5 rights of medications. Next risk is pressure ulcers, and I have a picture up there that you can kind of see, like if they're sitting up, or if they're either in a chair or sitting up in bed or even laying down, where those risks for pressure ulcers are. And ways that we prevent those is we regularly want to be inspecting that skin, making sure that they're turning or repositioning frequently. So if you notice that they have been sitting the same way in the wheelchair for 30 minutes or so, you might just say, hey, why don't you lean to your right for a little bit? Because what we want to do is get that pressure maybe off the other side for a little bit and put it on the right. And then sometimes we may have them sit straight up, so we're evening out the pressure. And then if they are laying in bed, then we have them turning and repositioning every 2 hours. Other things that we do is we have, of course, our air mattresses. We use pillows to help with positioning. And one of the biggies to keep the skin clean and dry. So respond quickly to those call lights, and let's try to keep our residents from getting pressure ulcers. Another risk is infections, and main ways of preventing it, of course, is hand hygiene. We talked a couple of months ago about only about half the people that go to the bathroom wash their hands, and actually I believe it was 3 out of 10 people, and then about half of that actually do it correctly, where they're getting all parts of their hands. Of course, if you're wearing your PPE, that can block you from getting exposed to any type of organism in the first place. Cough hygiene, sneezing, into, your elbow, into a Kleenex, into the inside of your shirt, and staying home if you're sick. So if you're running a fever, if you're vomiting, You definitely need to be letting Tana know, because on a lot of these illnesses, she has to keep a record of those that are occurring. And then we're still at that time of year where we know we've got a lot of cold, we've got a lot of flu, RSV, those types of things that are prevalent. And so sometimes social distancing is still the way to go. So for person-centered care, our facility, our main focus is on our residents. We want to provide them with individualized care because we want this to be a place where they actually can live and not just exist. We want them to, really enjoy, whether they're here for just therapy and they're going to be going back home, or if they're going to be staying here until they pass away. We want them not just to, have to just feel like every day they're just existing, but we want them to actually live and enjoy it here. We want to make sure that we are giving them their own choices where we can, and trying to give them a little bit control over their daily lives. A lot of times they feel like they have no control. Their homes may be sold. All their things that they used to have, they may have all been sold or given away, and now all they have is just what's in their part of the room. And so by helping them to feel like they're in control and they have choices, well, that's just one of the ways that we can help them to adapt and feel like this is truly their home. So why do we do that? Well, number one, it helps their health. If you're sad, if you're depressed, well, after a while, that takes a toll on your physical body as well. We want our residents to, if possible, we want them to be happy. We want them to be content and enjoy their stay here. Person-centered care also leads to improved satisfaction among both residents and their families. A lot of times when we have somebody that is going home, I love to hear them when they're talking about how well we've done and that they're going to miss us. That just, I have a grin on my face the entire time, to the point my cheeks hurt. I love seeing them get to go home, but I'm glad they enjoyed their stay here. When it comes to a reputation of our facility, we do have a good reputation, and a lot of that is because we do have our focus on the residents. And of course, better morale and productivity among staff. We really do get to know our residents. And, like one of my favorite things to do is come in sometimes and see grins on faces, or hear, residents singing, and that just makes my day. And we tend to get attached to our residents, and I think that makes it so that there's a part of our day that we do look forward to when we come in. So some person-centered components. We try not to just make their care just about their medical needs, but we also want to know what are their goals, and what are their preferences, what are their habits. And then we try to, if we can, we try to let them have those choices. Whether it might be they want to stay up later or they want to sleep in. We want to really try to maximize those choices. We want to try to keep them as independent as they can be for as long as they can be. When they come and they move in, I'm glad that it doesn't really feel like they're getting admitted to the hospital, but we want them to feel like they're actually moving in, and it to feel like a home for them. We definitely want to focus on what our residents can do and not what they can't. And not just focus on it, but we want to help them to be able to continue to do and to get better and to improve and to be as independent as they can. I think we do a really, really good job about supporting each other, whether it's residents or staff, through grief and loss. And then our dietary engagement, if they don't like what's the main course on the menu, we do have some other options, sandwiches, that types of things. I love that our activities department has been offering some special food experiences, so like the taco bar and the hot cocoa bar and those types of things. And I really think our residents like it as well. But the whole point is that we want to make this an environment where they can live and not just exist. So when it comes to change in condition, that is any change in a resident's status from their baseline. And that just means from what is normal for them. And we usually assess that when they come in on their admission, but sometimes it's from when they were in the hospital. And these are some of the different types of changes in condition. I've had housekeepers, I've had maintenance just say, hey, they're just not themselves. Well, if you tell that to a nurse, that may indicate to that nurse that, hey, we need to be checking them out because something's not right. Whether that's, they're more confused than normal. Well, confusion is one of the first signs of a urinary tract infection in the elderly. Or what if they've got some new pain? Well, we might get to look in and notice they've got a big bruise or they've got a skin tear, and that's the cause for the pain. Or this time of year, shortness of breath can increase because the cold air causes the passageways in your lungs, it actually causes those to shrink. And so air exchange isn't as good, which could be some of the shortness of breath. But then again, they may be, starting to get sick. And we just need to make sure that if we see anything like that, we're letting the nurses know so that they can be further assessed. So what do we do? Like I said, notify other healthcare team members. And it may be the next step after that is, hey, we need to let the physician or Celia know. The other thing is, especially if there's a change in treatment, we need to make sure that our residents and their representatives and their families are notified, because we don't want them coming in to visit their mom and they notice something's wrong with her and we hadn't told them. Well, then it looks like we're not doing our jobs, and sometimes it may feel like, we're leaving them out of their family's decisions. And we just want them to feel like they are a part of the process when it comes to taking care of themselves or their family. So ways to prevent. Number one, we do assess at preset intervals if we do have any status changes in our residents, so that we can determine, is the treatment that we're doing, is it even working? Does something need to be changed? Hopefully it's not at the point where they might need to go to the hospital, but those are things that we need to regularly be assessing. And just to remind you that residents, they may not necessarily report new signs and symptoms because they might think they're related to aging or a current medical condition. So for instance, it took me over 6 months to get my back looked at. And I was having a lot of trouble with it, and I just thought it was arthritis, to be honest with you, when I had actually injured my back and have had to get a lot of treatment. The next thing, when it comes to the plans of care, we do try to address possible risk factors. So for instance, if they have COPD, we're going to be looking, at how they're breathing, and we're going to be listening to their lungs, and, if they're coughing, is it productive? But we put those things in that plan of care, so hopefully we can keep a change in condition from happening in the first place. And then lastly, we look at recurring fluctuations in their signs and symptoms. Because if it's a normal thing for them, then we don't want them to be assessed for a change in condition if it is actually something that they do normally. So that is the end of the presentation. Hope y'all have a wonderful Christmas and a Happy New Year.